So we have progressed on to step 4, supraglottic airway or endotracheal intubation, and/or. If an airway is compromised, we talked about continuous compromised airway, one with vomit that cannot be cleared, whether it be continuous vomitus or it's beyond the site and we can't get it out, or we can no longer maintain the airway through basic maneuvers. It is time to progress on to either supraglottic airway, a king air airway, or a LMA, that kind of thing, or a combi tube, or to endotracheal intubation. Or in this case, if resuscitation has gone past 660 compressions with no VFib present. The intubation must be performed by the paramedic with the most experience in successful intubation. That is the paramedic on scene. We do not attempt more than 2 attempts per patient. That does not mean 2 attempts per paramedic on scene for that patient, only 2 attempts at endotracheal intubation per patient. We are going to apply O2 at 15 liters per nasal cannula prior to and throughout intubation attempt to provide passive oxygenation in an attempt to lessen the chances of hypoxia through intubation. If for some reason through movement of the patient from the scene to the ambulance or what have you, or through movement in the ambulance, the ET tube becomes displaced, and it is no longer ventilating the patient, we will remove it and we will replace it with a supraglottic airway in the interest of time and re-establishing the airway of the patient.